Hello and welcome to the launch of our new event series, Changing Healthcare, Learning from What Works in the NHS. We'll be spending our time today talking a little bit about the event series and why we think talking about successful change in the NHS is so important. Before we do that, I'd like to introduce myself. I'm Jess Tudor-Williams and I work for Kaleidoscope. We're a social enterprise who bring people together to improve health and social care. And with me, I have...
Hello, my name is Matt Tagney. I'm the Director of Planning for NHS England and Improvement, but before that I was also the Programme Director for the Long Term Plan.
Hello, I'm Angus Ramsay. I'm a researcher from University College London and an NIHR Knowledge Mobilisation Research Fellow.
Hello, I'm Lamont. I head up a national centre for disseminating research to the service, and I'm a member of the board of HSR UK, a health service research network.
And you can't see them, but in the background we've got Peter, who's in charge of our tech, Seren, who's on our social media, and Rose, who'll be managing any questions you have for us today. On that, there are a number of ways you can join in the conversation, and I think Peter is going to be putting a slide up for you now. To summarise, you can use the Ask Question feature on your control panel. You can email us via hello@kaleidoscope@kscopehealth.org.uk, or you can tweet us using #ChangingHealthcare @kscopehealth. We are also recording this webinar. If you have to leave halfway through for any unforeseen circumstance, it will be available for you to view on our website. And if you are a participant of the webinar, you will automatically be sent a link when it is live. Before we get on talking to our lovely guests today, I will also just mention that you can find all of the information about Changing Healthcare on Kaleidoscope's website. So now I've told you a little bit about us and what we're doing, I would be really interested, I think we would all be really interested in hearing who we've got online with us. So if you should now see on your screens a poll, and if you could just spend 2 seconds to select which category best represents you today. Okay, that's great. I think we could get any more. If Peter, if you could close the poll for me, that'd be great. So for your viewing knowledge and for ours too, we look like we've got 50% policy, 25% research and 25% management. That's really interesting. Cool, thank you. And now I have a quick question for you. So if you could use on your GoToWebinar control panel, you'll see a question function, and if you could pop in the one word which immediately springs to mind when we talk about large-scale change in the NHS. And while you're doing that, if I could ask Matt, what's your word?
My word would be potential.
Potential, nice. Angus?
Building on that, it would be potentially transformational.
And Tara?
Engagement.
Okay, and I'm going to go exciting. So I think the lovely Rose is going to pop up some of the other words we've got here. So we've got culture, involvement. Any others? Aha, confusion. Yeah, very reasonable. Continuous, nice. Yeah. Cool. If Rose carries on doing that, guys, are there any there that particularly of those four you're particularly struck by?
I mean, I think they're all really important. I think that the confusion and the continuous one I think are interesting. Yeah. And I think I get that. I think it can feel if you're in the NHS that there is an awful lot of change happening, and then it goes on all the time. And then it can be tiring, and I think we should acknowledge that is how it feels. But it's also part of why I love working in the NHS, because there is so much change happening, and there are so many incredible things that we can do now that we couldn't do 10 or 20 or 30 years ago, and that is kind of all possible because we have this kind of change culture and the kind of progress that we have.
Yeah, I suppose I heard that a bit more as it's building as well, the option of building on previous change and learning from previous mistakes, that kind of continuous process. We've got a couple more words here. Challenge, resources. Vision, that's an interesting one. You got any, Tara, Angus, anything you want to chip in on that?
Yes, it's interesting, isn't it? Vision is last here and probably first in terms of, I think some of the examples that we're going to talk about today, there is something about harnessing an overall goal, however difficult it is in the thick of it. Yeah,
cool. So thank you for that, everyone. So now I want to talk a little bit about changing healthcare, and Matt and Angus and Tara are going to give you a bit more on that in a minute. We think there's a real value here in Kaleidoscope in celebrating successful change within health. And so we built this particular event series looking at 4 case studies where we think there is successful evidence of successful change, either in policy or implementation or in both. So Matt, I was wondering if you could tell me a little bit about why you think successful change, or reflecting on successful change, is so important in the NHS.
Yeah, thanks, Jess. I mean, it is self-evidently hugely important. I mean, as I said, I've been working in health policy, or the NHS, since about 2002, and one of the things I love about it is just how much change there is. So if you think now about, if you're a 60-year-old in Manchester who has a stroke and who gets thrombolysis, who the rest of their life is could be significantly different and better as a result of getting that than what would have happened 20 or 30 years ago. Or if you're, an 8-year-old in Bristol and you've got leukemia and CAR T therapy is the thing that could make the difference for you. Those are kind of real changes that have come through kind of years of scientific research and trials and evaluation and clinicians working together with managers to work out how to make these changes happen. And I accepting that it can feel tiring and it can feel like it's happening all the time. But when you think about at the heart of it, that's what the change that we're achieving does. I find that really exciting and energizing. And I think that the long-term plan gives us a really fantastic opportunity in this area, because we've got certainty over the next 5 years of how much revenue funding the NHS is going to have. We know what the priorities are and what they're going to be and what we're trying to do over the next 5 years. And I think that gives us a really strong basis to deliver those changes, to make the improvements, to expand mental health care, to diagnose more cancers earlier, to put prevention at the heart of what the NHS does, to really drive down inequalities. And the reason why I think the long-term plan does that is it's partly about the money, but it's not just about the money. And actually, in fact, my experience of sort of witnessing and being part of changing the NHS is actually, the money helps, but it's the people that is really important. And it's the people working in the NHS and with the NHS and getting them to work together, and how we create that culture and that environment that allows people to take things that work and replicate them and understand why they work. I'd say that in the long-term plan, there's not much in there that isn't happening somewhere, either in the NHS or across the world already. And the real opportunity I think we have is to kind of build a culture where we are recognizing what works, not being shy about it, shouting about it, and replicating it across the whole country. And I think that the way in which we'll do that is probably a little bit different to how we've tried to do large-scale change in the past. There'll be much more recognizing of that and asking people to work together in systems, not to be within their organizations, not within professional silos, having a local plan across everywhere, having a local plan that's clinically owned, that's locally led, to deliver real changes over the next 4 years. And so for me, change is exciting in the NHS anyway. The long-term plan gives us a real opportunity, and I think how we're doing about it is also exciting. It's different this time.
Great, thank you. The passion really shows, which is fabulous. So last year we worked with the NIHR and delivered an event in learning dissemination from the stroke reconfiguration, and Angus was very lucky to be involved in that. So I wonder, Angus, if you could tell us a bit about how the stroke event went and why that learning was so important.
Yes, so happily, thank you. Yes, I was fortunate in the first place to be involved in some research that looked at a change that made a genuine difference to people's outcomes and quality of care. So looking at, so it's NIHR funded research, looking at the reorganisation of specialist stroke services in London, Greater Manchester and other parts of the country. We spent several years working on this, and at the end of it, we were then given the opportunity to apply for further funding to do so-called enhanced dissemination of our findings. So researchers are not necessarily the best people at sharing learning a lot of the time, and it's certainly something that I recognise there are gaps in on my part anyway. And what we really wanted to do in sharing the learning in a new way was to work with people who were expert in that field. So we had some connections already with Kaleidoscope, and we worked with Rich and the team to put this event together. So broadly, the event was trying to spread learning from these particular cases of reorganising stroke care in quite large urban settings, and thinking about how the lessons about these change might apply not just in other parts of stroke, but also in other parts of the country in relation to stroke, but also more broadly in terms of how change can be delivered in other care settings. And so a huge amount of work went into that between sort of January, May 2018. And a series of events. First of all, we developed a website which contains sort of a background to the story, the research, and the key messages, links to all of the findings, published papers, accessible summaries. Sent out a targeted set of invitations to a range of different stakeholder groups, clinical, managerial, policy level, and so on. Then a whole series of other activities to build momentum, so a series of blogs about key aspects, 2 webinars, one capturing the full story of the research, the other one looking more broadly at international experiences of conducting major system change, taking European experiences, Canadian experiences. And this all built up to a big face-to-face event in early May, which was held up in Union Chapel in Islington. Very nice. Drew together over 100 people, I think, from a wide range of backgrounds. We talked about a lot of the key issues in relation to this. So how one implements change, how one involves different stakeholders, and how one understands and evaluates whether it's actually made a difference. And that whole series of events and the outputs from that ended up being added to the website, added to learning more broadly. We evaluated things and we put together a sort of case study of reflections and so on it, which we then returned to the funder with various recommendations on how this might be done more effectively in future. I mean, I can talk a little bit about what sort of impacts there were as a result of it, which I think is important. So some of the key things would be at a basic level, there were a number of new collaborations that formed from that. So forming links with STP areas who were planning to do major system change but wanted support with their evaluation. The website as a product is something that we as the research team, we now share every time we present the research. So we put it at the end of our presentations, we link people to it after we've had a meeting and so on. And I've had feedback from frontline clinicians, hospital managers, regional managers, national policy makers, that resource has been pivotal in helping them understand the key impacts, but also extending their understanding of the underlying factors. So, for example, the impact on the impact of planning implementations on the sort of softer sides of the research. So yeah, I think these are some of the main impacts. I guess the other thing is just sort of personal learning, in terms of how one actually develops thinking and planning around, sharing knowledge, and it's something that I've drawn into a lot of other projects that I've been working in since then.
Thank you. And it was the success of that and that approach and exactly those kinds of impacts that you're talking about that led us to developing Changing Healthcare. And what we're hoping to do is take a number of workshops around the country, basically following that same sort of format for the days that we're doing, which leads me to Tara, who has got the easiest job of us all today and is going to summarise 4 highly complex cases of system change in 1 minute or less per case study. So, shall we start? Are you ready? So drum roll, everyone. No way overhyping this, of course. So, event 1 will be taking place on Tuesday, the 4th of February in 2020 in London, and it will be on the success of NICE. Tara.
So NICE now very much part of our landscape and much envied and copied by other countries. But it was set up in 1999 to do two main things which weren't happening at that point. So one was having a robust process for assessing the cost effectiveness of new drugs, the kind of fourth hurdle, and the other was to provide sort of evidence-based, agreed national clinical guidelines. So at that time, there was, for instance, over 160 separate guidelines for asthma from different localities and professional groups. So the success of NICE has been providing more sort of consistent care through this programme of national guidelines, so that 4 out of 5 people talking about stroke would achieve getting the thrombolysis door to needle time within the recommended 4 hours. So having those national standards. And looking, what we hope to explore in the seminar is some of the reasons for the success of what was quite a kind of radical new departure. So why then? Well, it's partly a new government embracing sort of rational decision making against a backdrop of much public concern around postcode lottery, the Child B case, and also ministers, I think, wanting to distance themselves from difficult decisions about high cost new drugs in cancer and other areas. There's something about the success of having a kind of top-down initiative which aligned with something that was happening anyway in terms of a bottom-up movement in the clinical communities around evidence-based healthcare. So people like David Sackett promoting the work of Archie Cochrane on the need for us to really know which treatments work, and in the 1990s having the machinery through a new health technology assessment program, health economic tools, having a way to assess and compare the effectiveness and cost effectiveness of treatments. There's something too about stable leadership. So NICE is unusual in its 20-year history of having a very stable sort of 3 at the top and having the robustness to be able to counteract what are still quite sort of, they weathered challenges from the pharmaceutical industry, from perhaps ministerial interference on very difficult decisions, Relenza, Herceptin and so on. So I think there's a lot to learn, and certainly other countries want to learn from the success of NICE.
Okay, fantastic. And Matt, envelope time.
Envelope number 2. So envelope number 2, event 2 is on Wednesday, the 1st of April in 2020 in Birmingham, and it is the reduction in healthcare associated infections.
Tara.
So I think for those of us old enough to remember, in the early 2000s,
Pointed at me then.
There was a real climate of concern with headlines about killer superbugs and so on. 90 deaths in Maidstone, Stoke Mandeville. There was a catalogue of what was seen as a real kind of crisis in the health service. There was a very successful series of interventions, from sort of mandatory surveillance and reporting, so collecting data for the first time really on MRSA and other infections, setting targets, the importance of kind of top-down targets, and also evidence-based bundles and national campaigns, things like Clean Your Hands and so on. And the trust met and exceeded these targets. So it is a real success story. And it's hard in a way to attribute success to any one factor. But from the evidence base, Mary Dixon Woods did a very interesting evaluation of a similar program in Michigan in the States, where she talks about the importance of framing the problem of healthcare associated infection as a social problem, as something that was fixable, whereas before perhaps it had been just accepted as an inevitable that you would get a sort of rate of infections. we're looking at themes in the seminar that we hope to explore about the model of both sort of strong national leadership, but also this kind of distributed leadership. So not only having points of responsibility and accountability within trusts with Directors of Infection Control, but also very much having distributed responsibilities with clinical teams across organisations. And having sort of clinical champions to make sure that that change was sustained.
Cool. Okay. And Angus, red, auspicious colour.
Exciting. So event 3, that's going to be on Tuesday, the 12th of May in Bristol. And its topic will be increasing day surgery.
So day case surgery, I think now, recognised to be a good thing in terms of a shorter length of stay, cost savings, but better outcomes for patients. But again, a success story in that we now have, more than 98% of cataract surgeries are done as day case, and overall, across a wide range of elective procedures, at least a third are done as day case. And what started out being just for kind of younger, fitter, easier procedures, you now have even sort of angioplasty and so on done as a day procedure. And that was possible both, again, it's this confluence of different events, of both technological advances, so short-acting anaesthetics, and the development of minimally invasive and keyhole surgery. But also this important facet of clinical leadership. So I think 20, 30 years ago, there'd be isolated enthusiasts which coalesce as British Association of Day Case Surgery, who work very closely with the government in setting targets. So again, some element of important kind of top-down activity, starting off perhaps with pressure from the regulators. So the Audit Commission was quite influential, I think, with its basket of procedures that could be done as day case, but then followed up by targets, by DH Task Force, by the high impact changes, that sort of 2004 influential report, recommending that day case be considered as default for many procedures, and a best practice tariff to incentivise clinicians and organisations to do certain procedures. So again, it's a combination of interesting factors worth exploring.
Cool. I should say, before we get to the fourth and final envelope, that we will be taking questions from you all after Tara's told us our fourth topic, and you can put those questions in using the question function on your GoToWebinar panel. And with no further ado,
I think I know what it is. So it's implementing non-medical prescribing. It's actually quite an important sort of feature in the long-term plan. So UK is not alone in extending prescribing powers to people other than doctors, to nurses, and to allied health professionals, but actually is at the forefront. So the UK has nurses with independent prescribing powers have greater powers in the UK than anywhere in the world. And many European countries haven't extended those rights to allied health professionals, for instance. So UK is at the forefront of this. It's been perhaps over 20 to 25 years of quite gradual movement, moving from sort of initially for nurses quite restricted supplementary prescribing powers through to more overall clinical management and prescribing rights. So there's now over 58,000 prescribers. I mean, interestingly, a recent survey of pharmacists showed that many were trained and able to do this, and perhaps were still underused. So there's a question there about whether there's still more that could be done. But I think a recognition that it's a really welcome development, given both pressure on doctors and also some evidence of sort of prescribing errors by junior doctors and so on that drove this. But more importantly, we know about the needs of complex patients with comorbidities, that it's very different, polypharmacy, very difficult to make the right prescribing decisions, and for patients to have to wait for a doctor to prescribe when they may be seeing a district nurse or others who are perhaps better able to see the kind of holistic needs of the patients. So in terms of success, a Cochrane review quite recently, looking at 46 studies, mainly nurses, but also some pharmacists, showed equivalent or even higher levels of quality, fewer prescribing errors, and high rates of patient satisfaction. And I think it's a really interesting area in terms of changing scope of practice, and perhaps this incremental change. So some of the early pilots of the supplementary prescribing were evaluated and then sort of built on to extend the powers further. But I think we can see example from ward-based pharmacists to sort of nurse-led clinics for diabetes or asthma, where extending prescribing powers have and could make a real difference.
Thank you for that. Tara was so excited to talk about non-medical prescribing that she forgot to tell you the events on the 7th of July in Newcastle.
I'm so sorry.
That's quite all right. So we've got about 10 minutes for questions. I think some people have already been putting some questions down for us to have a look at. If you'd like to ask us a question, please do use the question function on the GoToWebinar, and Rose will make sure that we see them. I would like to open with a question for Angus, actually. Don't look scared. So I'm interested to know what you think it was about the stroke reconfiguration events and the way it was approached that made the learning so impactful.
So I think there were a couple of things. I think one thing was the learning from the reconfigurations themselves. And so there was something about the fact that the changes that we studied, we had something of a sort of natural experiment where two large, quite equivalent areas did different things in trying to sort of reorganize their stroke services. And we were able to look at these changes from a number of perspectives. So not just looking at whether it worked or not, but also the how and why of it. So we were able to provide sort of potentially contrasting results and explanatory qualitative data. And we were able to draw from these quite compelling lessons about how you conduct change of this kind. In terms of the event, I think one thing that really made a big difference was this. There were a couple of things. I think the focus on getting as many different perspectives as possible and asking people to think outside the stroke context as much as possible was really valuable. I think using multiple methods for getting the message across, so not just having a big event, but having these webinars, having these blogs and so on, providing different facets of the learning in different ways, really important. I think the sequencing played a really important part. So this idea of building momentum over time, really, really important. And underlying that, I think, comes down to sort of working with people like Kaleidoscope, people who have an expertise in those dynamics of learning is really important. So that would be my answer.
Thank you. And Matt, listening to that, why do you think people working in the long-term plan now should be coming to this event series?
Well, I thought when you were talking through, Tara, I thought the one thing was great was for every single one that you were talking about, there was something that I thought, yes, I can see how we've taken the learning that you've described and are applying it in how we're trying to kind of make change happen as part of the long-term plan, whether it's kind of that focus on independent evidence and scientific evidence and rigor, or whether it's about kind of getting the right combination of kind of a national target versus, recognizing things as a social problem and a social issue and clinical champions and clinical leadership. So and an area of the non-medical prescribing where the UK is, at the forefront of kind of, of leading the world in kind of some of this stuff. So the bit that I took out from it was that there are huge cut across things in all of those topics that are really relevant to how we're going to implement the long-term plan, the changes we're making in the long-term plan, which one is encouraging because it shows we're learning, and two, I think means that if people are going to those things, I'm sure they will be picking up techniques and ideas of what works that are applicable, not just in those fields, but beyond and across the whole breadth of what we're doing.
Thank you. So going to some of the questions that you've sent to us, we've got a nice one here from Alex. What role do communications and communications team play in supporting change? Matt, do you want to start with you?
Yeah, I think communication is really important, because I think, as we've been talking about, so change is about getting generally it's about getting people to behave differently and to interact with each other, some of them being service users or other clinical professionals or management, in a different way. And I think if you haven't managed to communicate to people what is it you're trying to change, why is it a good idea, and as part of communication, obviously being listening as well, and listening to what other people think we should be doing, then you are immeasurably less likely to succeed at what you're doing. So it's really important to me. I don't think you can do successful change without having good quality communications.
And I think too, the infection control example shows us the importance. It's a combination, isn't it, of stories and statistics.
Really nice.
I think the learning, the developing a sort of community of practice of people who are doing similar sort of service transformation schemes, having some opportunity to benchmark or to gauge progress, but also having those kind of sentinel events. I think Mary Dixon Woods again talks about there was a toddler with a catheter infection who died in Michigan, who became the kind of the poster story for really motivating staff.
And I think it's exactly that. Articulating the case for change, communicating that well, is so powerful and critical in bringing people together. So thanks for that, Alex. Great question. So we've got another question here. All four of the topics sound great. Is the aim that people would attend one of the events or more than one? And will there be other outputs from the events, like a video summary, vlog, blog, etc.? So shall I start with that, Tara, and you can kind of pick up a bit? So we've designed the events so that they will be complementary, which means you can come to all four if you want to. And what we're hoping to do from each of those is build a kind of curriculum of change. So you'll get key themes out of each event, which will help to contribute to give insight into what contributes to successful system change. But if you can only come to one, Bristol, Newcastle, London or Birmingham, then it will stand alone on its own as an event. But the idea is that we'll produce lots of content. There will be additional webinars, blogs, and a standalone mini site on the Kaleidoscope website, which will have all of those resources in as well. So anything else you want to add from that?
No, I mean, we are designing the sessions so to the panels and the speakers will bring very different perspectives, I think, from kind of historians to, clinical leaders to others. So I think there will be some sort of learning and insights that, you can't quite predict really what's going to come up at each. So it'll be good.
And we've got a great question here from Helen. Clinical networks don't often get a mention in the write-up of the stroke story. What's the role for these kind of brokers in the system? And I think Angus and Matt would be really keen to hear your reflections. Absolutely.
Well, the first thing that I'd say is, well, my bad. We've published quite a bit on sort of implementation of the changes and so on in stroke, and the clinical networks were pivotal in delivering those changes. So the changes in Manchester were led and driven centrally by the local stroke clinical network, and the and the clinical network were absolutely fundamental in London to ensuring that the services were developed and implemented in a consistent and effective fashion. The remainder of the clinical networks remains today and is pretty pivotal to the ongoing sustainability of those systems. So I'd argue that the networks playing a really important role in terms of ensuring services continue to develop, They are vital in ensuring effective cross-organisational working, and in any sort of complex change that involves a network of organisations, you do require that sort of glue, but also an honest broker that facilitates tough discussions between organisations. Yes, I can very happy. We can. It's all on the website that we put together actually, and we can definitely link you to that. So thank you for that question.
Matt,
so just to add to that, so the job I did before the long-term plan, I was program director for the maternity transformation program, and clinical networks were, I found, hugely useful and valuable in doing that experience. So the ability to get together, a group of clinicians working across a kind of a wider geographical area and get them in one room, or virtually even, and say, this is what we would like to do. Is that right? How is it going to work? How can we help you to do that locally across your patch? And also the feedback you would get from them on, when you came 6 months ago and you said you're trying to do this, actually, this is our lived experience of having done that. These are the things that are difficult. So what are you, as from NHS England and Improvement, going to do to help us to do that? And I found that feedback really, really useful in kind of working out how we could work together to make change happen.
If I could add one thing, one thing that I missed, but which builds, thank you, which builds on Matt's point. It's not just about engaging with clinicians. One of the biggest stories with changes of this kind is that it involves far more stakeholder groups than that. So it's not just clinicians, it's managers, it's commissioners, and so on. And again, in the stroke story, it was really, really telling how important it was to keep the commissioners in as part of the story. So the networks were vital for that.
And that comes back to the earlier question around communications as well.
Yes.
Unfortunately, we're out of time for questions now, but I just wondered if I could ask you guys to just give me a quick reflection based on the conversation that we've had about the event series and about the importance of successful change in the NHS. So I'm going to start with Tara this time and come back this way.
I think, as Matt says, I think there are some sort of common themes actually across those four topics that we've picked, and that mix of kind of top down and bottom up, and what we've learned from good sort of UK based research and evaluations. So I think there will be some sort of take home lessons of quite a practical kind, but also perhaps a sort of rethinking and perhaps just sort of framing some of the issues. And we had another question about, how else could we use technology to bring about change in healthcare? And I think that for each example, like day case surgery, it's sort of sparking off, how can we think about bringing care closer to home using technology and all the other sort of changes that we want to achieve. So I think they should be very stimulating events.
Great, thank you.
I think some of the points that were raised by the audience at the beginning, so things like vision, complexity, challenge, continuity, and so on, are issues that spread cross-cut right through any challenge, any effort to conduct a change of this kind. And therefore, hooking these events to some of these broad concepts is going to be, one of the key contributions of an event series like this, I think.
Cool. Thank you.
Yes, I've really enjoyed listening to your reflections, Angus and Tara, about the work that you've been involved with. I think that the lessons that we can draw out of it, that's a common crosscut, are brilliant, and it's really good to kind of keep those fresh in my mind as we kind of think about how we're going to support the NHS to make these positive changes across a pretty broad agenda over the next 4 years. And I think right at the start, just the reminder that as I sit here being all sort of passionate and sparkly-eyed about changing the NHS, that it doesn't always feel like that to the people out there who are doing it, is a really good reality check as well. And so we definitely need to keep in mind. So thank you for that.
Thank you, Matt. So hopefully we've given you a flavour of what these 4 events will be. They're free. You'll be spending a day with a really diverse group of people, having a lot of stimulating conversations, but most importantly, they'll be focused on the learning that we can take away back to the day job to affect successful change in the NHS. As I've already said, there'll also be loads more content produced through webinars, blogs, and a website of resources. So it would be really worth getting involved in the programme. I'd like to thank Matt and Angus and Tara for joining us, and thank you all for logging in today as well. Peter's just going to pop a slide up for me which reminds you of the events and where they are, and of course you can find everything you need to on our website, including the link on how to register for the events. You'll also find detail about the speakers who we have confirmed already, and there are some really exciting people coming along, and we can't wait for the days. Thank you, Peter. So it remains to me to say thank you to you all again, and thank you from you all, and we hope you have a lovely rest of your afternoon.
Thank you very much.
Thank you.
Thanks.